I'm going to spend about 10 minutes giving a pretty broad-ranging talk about concepts of bone resilience, specifically relating to the athlete. I want to emphasize the multifactorial nature of bone resilience when we're considering injuries in athletes. And I'm, of course, going to talk about bone stress injuries because that's often when we start to question bone resilience in our patients. How do bone stress injuries happen and why do they happen? And I'll talk a little bit about screening bone resilience as part of our routine evaluation of athletes in their medicals. So what is bone resilience? Well, in the general population, we would say it's the ability of a bone to withstand the loads being imposed upon it. In the athlete, it's slightly more far-reaching than that because, in fact, it's a bone's ability to resist what are essentially multiple, repeated, varied loading stresses on repeated occasions over sustained periods. And these loads would be considered to be supraphysiological in the general population. So these are high-loading programs, and therefore they have a rather unpredictable effect on an individual athlete. And that's why the concept of bone resilience can be quite complicated to tease out in an athlete with an injury. So I like to divide the areas of discussion into these three components. Components related to bone properties, part of which is what we classically describe as bone health, the mechanical loading cycles and the mechanical stresses being imposed upon that athlete, and the ability of the individual to recover, remodel bones, and adapt to the stresses that are being imposed. And any discussion about bone resilience really needs to start with a little bit of simple bone biology. So this is Wolff's law, which is pretty simple. It talks about mechanical strain upon bones and the fact that when you impose mechanical strain on bones, the bones react, hopefully adapt to that strain, and then become stronger for it. And they respond and adapt predominantly in the adult through bone remodeling. And this is a picture of a bone remodeling unit. So the bone remodeling is what's called a coupled process. We have osteoclasts that are activated to resorb the bone and take away a bit of the damaged bone. And then as this occurs, the osteoblasts are activated and essentially are involved in bone formation. And following that, then there is an activation of the mineralization process to make the bone mature and sound and resilient to the typical load. Now, one of the things that will activate this bone remodeling is microdamage. And microdamage is a normal phenomenon, and it can take many different characteristics and occur in many different ways within a bone. But this is a picture of a linear microcrack within a bone. And we will have these all the time, and the bone responds to this microdamage, and it responds through it by triggering the remodeling process. So what we see in this picture are the microcracks here, where the arrows are pointing, and then these are resorption spaces within the bone. So this is this part of the remodeling process. Now, these are all tiny little areas in bone that are helping the bone to remodel itself under the mechanical strain. And it's all part of that natural process that should occur and shouldn't be a problem. But if there isn't, for example, resilient bone to back up the load that is being imposed elsewhere, so if there are problems with bone properties, or if there are excessive mechanical stresses upon the bone that are ongoing, or if the individual isn't able to recover in the way that they should from those loads, then that's when we run into some problems. So there is an accumulation of the microdamage as opposed to the repair that's occurring within the bone, and that is when we start to see bone stress injuries. So I'll start, first of all, by talking about the different things that can contribute to that process. And when we're talking about bone resilience in an athlete, most of us usually start to talk about, again, bone properties. And what properties are we interested in? Well, bone health, we usually talk about bone quantity and the physiology, the turnover, the remodeling of the bone that's happening. There are other really important elements that I'll mention briefly: the composition and the architecture, the way that individual's bone is designed, that will give it normal quality. And then we are also very much aware that the geometry of a bone very much influences its toughness, and that geometry is often dictated by what happens in loading in earlier life to make the bone suitable to take on those loads. So you have to have enough bone, you have to have good quality bone, and you have to have bone that's shaped in the right way. And if I start just with quantity of bone, at any stage in life, the amount of bone that an individual will have will be a reflection of the amount that it's built over the course of growth, and then the rate at which one begins to lose it. So we're very interested when we're talking to athletes about their bone resilience as to has there been anything that might have influenced in a negative way achieving a high peak bone mass. And when we look at the factors that will influence achieving a peak bone mass, hormonal issues such as a delayed puberty in gymnasts, genetic factors, is there a history of bone injuries in the family, any illnesses that might have affected bone development, or indeed immobilized the patient to the extent that they would not have had that mechanical stress on the bone, nutritional deficiencies, and very importantly, mechanical loading. And most of us will say to patients in adulthood, you know, did you do sport as a child? But it's actually what they did as a child that probably will influence the resilience of their bone. So if you were a child and did a lot of running sports or swimming and cycling, and then went into triple jumping as an adult, your bones would not have necessarily formed geometrically and in terms of the amount of bone mass that would be optimal. So we should ask our patients not only were they active in childhood, but what did they do in childhood. Then in early adulthood, or the ages that we're seeing a lot of our athletes, essentially they're consolidating that bone mass and hopefully maybe developing the bone a little bit further, or losing at a very, very slow rate, if at all. And so when we are thinking about, is there anything that might be impairing an individual's bone resilience in that phase of life, you're thinking, is there anything that could be causing them to increase bone loss? So a higher rate of bone loss in those patients. And we think about the fact that actually this means that this process of remodeling becomes uncoupled such that the osteoclasts resorb more bone than is being formed later on. And in sport, we would think about things like hypogonadism in the athlete triads, nutritional deficiencies, and various drugs, including proton pump inhibitors. Now, those are the things that we think about in bone health as such. And Rich is going to talk a little bit about looking at bone remodeling. There are lots of other things that we recognize might affect an individual's bone resilience. The type of bone present within that particular bone, the distribution of the bone across specific sites, and as I've said, the geometry of the bone. And some of these, the distribution of your bone density is actually genetically determined, but different genes seem to modulate different places at which you will build more bone density, which is interesting and still needs to be teased out. So this is just a summary of the bone imaging side of things that we talk a lot about DEXA, and we sometimes use a bit of CT, but in terms of looking at the tissue properties of the bone in some individuals, sometimes we just have to draw a conclusion that there's something different about that individual's bone that we can't quite measure yet. Moving on to the second area, which is mechanical stresses upon bone. When we talk about mechanics of bone, of course, everybody in terms of stress fractures wants to talk about biomechanics. You know, this is controversial. We could talk all day about which particular biomechanical feature may drive which injury. But what we're quite poor at is stopping and thinking more about, well, what's the timing of the loading, what types of loading are being performed, and what recovery strategies do we have. So the first thing to say about loading for osteogenic benefits is that if you have a certain amount of loading you want to do in a 24-hour period, then you are probably better off dividing that loading into discrete bouts of loading to promote best osteogenic response. And there should be a period of anywhere between 4 and 8 hours to optimize the sensitivity of osteocytes to loading. So this varies between sites and individuals, and some people say that actually some people will take 12 hours to respond properly and to become much more sensitive to the positive benefits of mechanical loading upon bone. And so if you do not allow adequate time between these smaller bouts of loading, or you try to do all the loading in one session, then the osteogenic stimulus is much less marked. Moving lastly on to remodeling, recovery, and adaptation. Again, do we promote recovery from training in bone as we do for muscle and other aspects? How much do we think about recovery strategies for bone, much as we spend a lot of time talking about recovery strategies for other tissues? So rest, good timing of nutrition, and sleep deprivation is known to impair good bone remodeling. All of these factors are really important. And we should also note that the remodeling cycle in a bone takes a long time. It can take, on average, 4 to 6 months. It can take a lot longer in other individuals. And actually, the formation and mineralization process is the longer element of that. And not only that, but different bones remodel at different rates, so the recovery of different bones to high stimuli may be quite variable. And this is why we might measure the vertebra as a site of a early remodeling, early loss of bone, because the remodeling is much more rapid in these bones. So to summarize that, remodeling and adaptation occurs at different rates, at different sites in different individuals. Not all of that is measurable, but we just have to learn very thoroughly about our patient to understand things. And lastly, I've mentioned screening for bone resilience. When do we start asking about bone health and bone resilience? After the patient presents with the injury. It's something that we should screen for as part of the annual medical or the biannual medical or whatever else. We should ask, you know, the highest predictive factor of having a bone stress injury, like most injuries, is having had the injury before. What is the childhood and family history in relation to bone health? Consider the potential reasons why an individual might have a more rapid bone turnover than they should. Look at the mechanical loading, the types and timings, and look at recovery from training strategies the patient's following. So in summary, bone resilience is really an individual athlete's ability to cope with what are essentially repeated supraphysiological loads. It's multifactorial, and when you're looking at a patient with a bone stress injury, make sure you cover all of your bases. It's influenced by a huge range of properties, not all of which we can measure, but we need to do the simple things well about looking at the small elements we can change in people's programs, including how they train, how they load, and how they recover. So I will finish there. Thank you very much.
I'm going to discuss the radiologist's perspective on assessing bone and monitoring healing a bit when the resilience fails. Okay, so that's when we tend to monitor it. I've got no disclosures. So I'm going to kick straight off with stress fractures. Common finding in the sporting foot as a result of what we think of as abnormal load on normal bone. Plain radiographs are poorly sensitive to this. And I think that's very important to remember. So if you have a very high suspicion of an injury to the foot, do not rely on your plain film radiographs and move quickly on to cross-sectional imaging, such as an MR. However, you may get some positive findings, such as the grey cortex sign, which is just subtle, very early sign where you get subtle loss of the cortical density at the site of a metatarsal stress fracture, for example. And it's important to know which sites fracture. So here on this example, you can just see subtle periosteal reaction at the medial border of that metatarsal. And so you have to actively look for those areas where there may be a potential stress fracture. You may get cortical thickening, and much later you may see a fracture. So we would have a very low threshold to move on to cross-sectional imaging. Typical sequences would be a fluid-sensitive sequence with a T1 sequence for anatomical detail. And so you can immediately see how much easier it is to see either a stress reaction in the bone, which is where you just get intraosseous bone marrow edema, but then you may get this subtle periosteal reaction again, but seen a bit more clearly on the MR imaging, and you get circumferential soft tissue edema. And so you know that there is this subtle stress fracture. Now, how would you follow it up? So the healing process is also important. And I think with metatarsal stress fractures, obviously clinical findings are very important, but this is an example where you will see the healing process on radiographs further down the line. And this is the case at 1 month. This is a different patient with a 4th metatarsal fracture. You can see very soft callus forming at the site of this stress fracture, and then later on at 6 months they have mature lamellar bone, and so it's completely healed, and I'm sure the patient is asymptomatic at that point. Really, I think, do we need to use CT in those instances? Ultrasound, however, is quite important. I haven't got a slide up of that, but I have seen occasionally patient comes in with forefoot pain, you do an ultrasound and you actually see a step deformity of the metatarsal. So actually ultrasound can be quite sensitive. This is another example, calcaneal stress fracture. Patient presents with heel pain. Often you won't see anything on the plain film radiograph, but again, the clinical history is going to be important, and if you suspect a stress fracture, we should move quickly onto MRI. And again, you can see quite diffuse bone marrow edema within the calcaneum, and you will see this linear low signal line within it, consistent with a stress fracture. How would you follow these up to assess these are healing? Obviously, clinically is important again, but we would go and probably continue with an MR on this occasion, not radiographs, because it was difficult to see in the first place, often difficult to see further down the line. And what you'd be expecting to see is resolution of that bone marrow edema, but you may still see this sort of microtrabecular linear low signal line still persisting for quite a while after, actually. Okay, this is an example of a 29-year-old runner who felt a snap on heel strike. This was their plain film radiographs. Don't know if anyone can spot the injury. Important to be aware of all the other sites of stress fracture. So I would look at the radiographs and I'd quickly go through all my areas where I expect a stress fracture and scrutinize them quite carefully. Base of the 5th metatarsal is one, the great toe sesamoids, talar neck. And indeed, this patient has this navicular fracture, which you can see there, lucency through the navicular, articular step deformity, quite a potentially disastrous injury. They go on to have an MRI. This is this patient's MRI. And you can see this sagittal plane fracture extending from the talar navicular articulation to the navicular cuneiform articulation, and beautifully seen on MR. This patient also went on to have a CT, because CT is really an excellent tool for clearly delineating the fracture line, being careful to know exactly where it finishes and ends, whether it's intra-articularly extending or not. And this is this patient. So they obviously went on to have an open reduction internal fixation of that fracture. Now, how do you assess the healing of that fracture? MRI, not really going to work. You have a huge amount of blooming artifact. It will be very difficult to assess for osseous bony union. So we would do CT. And CT nowadays, really, we can employ some excellent metal suppression software, and you get beautiful detail, really, of the healing process. So this is the patient at 0 months, which is what we saw initially. This is it at 3 months. So this is obviously a screw line, not very much metal artifact streaking, which is nice. Looks like there is some healing here at the level of the screw, but up here there's a persistent fracture line at the top. And in fact, you question whether there is some propagation of that fracture. So this patient went on to have a repeat CT at 6 months, And in fact, that fracture has not united and in fact propagated further. And you haven't got all the slices here, but that screw was depressing into the fracture site as well. So not a good outcome for that. Subchondral insufficiency fractures, otherwise known as spontaneous osteonecrosis. We see that a lot. You'll be probably more familiar with that within the central weight-bearing portion of the medial femoral condyle, but we do see it also in the foot and ankle. It is typically characterized by a curvilinear low signal line paralleling the articular surface, large amounts of bone marrow edema, large amounts of soft tissue edema. And I think that sometimes really distinguishes it from an osteochondral lesion. People say to me, well, that could be an osteochondral lesion, but actually it's that large amount of edema and often soft tissue edema, and obviously the clinical history. And this is a typical fracture that occurs when you've got inadequate bone or quality or mass, and I know Cathy's talked about the resilience of bone, and you get marked bone marrow edema. And the workup is really, I would recommend bone workup, which I know Richard's going to talk about, and DEXA scans. So osteopenia, I just wanted to touch upon this. Classically, you see decreased bone net density, but we know that radiographs are very poor modality for this, and you need almost 30 to 50% bone loss required to really appreciate that decrease in bone density. You get narrowing of the cortex, less than 25% of the entire metatarsal, but really that's quite a late sign. I just want to say not all bone marrow edema is stress-related. And so as radiologists, although we see bone marrow edema, you sort of want to jump to saying stress fracture, stress reaction. It is quite important to think about the clinical history here. So this was actually a 27-year-old runner, pain overlying the first metatarsal base. You can see here that they had lots of bone marrow edema at the base of their first metatarsal, maybe a little low signal line there, difficult to know. But the patient's clinical history was they were getting night pain. And really that is a red flag sign. It doesn't fit with stress fracture or stress reaction. And so we went on to do a fine cut CT through this patient, and they in fact had a well-defined rounded lucency at the base of that first metatarsal, at the epicenter of that bone marrow edema, and that is an osteoid osteoma. And this patient was a junior doctor who then went on to Stanmore to have radiofrequency ablation of that. So be aware that not all bone marrow edema is stress-related, and you've got to make sure you're not missing something else. So in summary, stress fractures, I would say radiographs are fairly insensitive, have a low threshold for MRI imaging if you suspect it, follow up maybe with radiographs, certainly with the metatarsals, but perhaps MR imaging and, for example, calcaneal stress fractures. If they have had operative management, I would suggest CT to assess that there's osseous union. For subchondral insufficiency fractures, remember that it's a curvilinear low signal line parallel to the articular surface. Those patients need bone workup, and not all bone marrow edema is stress related. So in the back of your mind, make sure that it fits the clinical history.
So yes, so I have a couple of disclosures. So what I'm going to do is basically build on what Cathy's talked about and just sort of highlight how we can sort of monitor the bone health in sort of from the physical side in the clinic rather than looking at the imaging. And we've heard obviously about the osteoblasts and the osteoclasts and the osteocytes and how those are integral to sort of the bone metabolism. Cathy's also illustrated the bone remodeling cycle, and again it is this sort of constant process, and over about 7 years your athletes and patients are going to basically remodel their whole skeleton. And essentially that's sort of what you would find in your sort of 25-year-old individual. Obviously after a fracture the bone formation processes are going to be much more switched on, so you get this uncoupling of bone formation and bone resorption. And what I'm going to highlight really is how you can sort of try and get a handle on what is happening, because yes, you might have the radiographs that have shown there's a fracture. You might then have to wait 6 weeks, 8 weeks to repeat the X-ray. You want to have some idea, hopefully, that the bone metabolism is normal at the beginning and it's doing what it should be, what you would expect. So there are a variety of bone markers out there that have been sort of historically used over the years. Some obviously are now, and I'll highlight the two that are now sort of in routine use and have been recommended. Some of these obviously have got certain issues with regards to urine collections and 24-hour samples, etc. But essentially now, very easily, you can measure a marker of bone resorption and a marker of bone formation with a simple blood test. So the marker that's sort of the classic for the osteoclast function, bone resorption, is serum CTX. Basically, it's listed there, basically what sort of the IOF sort of say about the assays. Most sort of laboratories will have them. They're available in quite a few of the NHS facilities. Also, a laboratory like TDL will run them. I'll discuss a little bit about some of the variability in these assays, but one thing to be aware of is that ideally the sample needs to be taken fasting. If you can't do that, try and make sure that if you're doing your clinic and you're seeing your patient, you see them at the same sort of time. So if you always run an afternoon clinic, it's fine, as long as you're consistent with that. But again, it probably also needs to be dealt with reasonably quickly. So you've got to be on site, probably getting it done, getting it frozen, and then it can be packed off to the laboratory to be dealt with. Serum P1NP is the marker of bone formation, and again, the characteristics of it are there. It's very well a good marker of bone collagen synthesis. The attractiveness here for a lot of people is that it's a much more robust assay. So you can put the blood sample, you can put it in an envelope, post it off somewhere. 2 days later, it might arrive in the laboratory. You're still going to get an accurate assay. So it's actually a bit more, it's a lot more robust than the CTX, but it's giving you a marker of bone formation. So in that respect, it's a very good, reliable marker. In some of the osteoporosis world, it's also used actually as a marker of osteoclast function because there is this coupling between the two processes. So if you're just running an osteoporosis clinic, this might be the marker of choice. If you want to understand the difference between resorption and formation, then you need to do the two markers together. So the markers are affected by a lot of different things. Some of the things you can control, some things you can't. So these are the uncontrolled variables, and we'll talk a little bit about I've got a slide illustrating what happens with these markers with fractures. But again, there's lots of things that you have to take into account when you're interpreting the results. And again, particularly if you're doing longitudinal assessments, what might have changed in that individual, what might then influence these readings. There are obviously then things that you can control. So again, we talked about timing of the sample, fasting status, and again, you'll need to be aware in your activity thing. Are you seeing your patients, and athletes, when they're active? Is it in the closed season? Because we know markers and bone health will change during the off season. So there's things just to be aware of. And just to illustrate a few things. So again, this is just looking at the relationship between formation and resorption in women in different ages, and you can again see obviously there's a much more formation in the younger groups, and obviously as you get to the older groups, then the resorption takes over. Again, if you're looking at your timings of samples, there's a seasonal variation, just as illustrated here, but with sort of some of the slightly older historical markers. But again, on the left, you've got bone formation. On the right, you've got bone resorption. So you can see there are differences. And again, it will determine if you're measuring things at 6 months intervals, you've got to take into account this natural variability. And also this diurnal variation, so fasting samples. So again, it's something just to be aware of when you get these results back, and being aware of, is the change real or is it dependent on other factors? So this is, again, a very interesting slide. It's actually quite an old paper from about almost 20 years ago. But again, it's looking at some bone turnover. This is looking at bone formation markers, but in patients following ankle fracture. And again, what you can see, so the sort of the dark black line is the mean, the individual plots of all the patients that are there. So what you can see is that in the sort of the first few days after a fracture, you're seeing quite a lot of bone formation happening, and actually it still stays quite high. Up to a year later, you're still picking up sort of increased levels of bone formation. But you can see from the sort of the scatter plots that, that actually all from the individual lines, there's a lot of variability around there as well. Some patients are obviously going very, very high, and some patients are actually a bit below the mean. So there may be other factors that are happening there, which you obviously need to be aware of. And Cathy was talking about some of the endocrine issues, etc., that may be relevant. And again, we know that in patients that are amenorrheic, they have low turnover states. So it may be that patients, individuals with the lower levels, may be people that need other hormonal treatments, etc. So one area that I'm interested in is not only can you sort of get some idea of what's happening and whether individuals have got what's happening with their bone metabolism, but can you use drugs then to aid fracture healing? The treatment that's been around for at least in the osteoporosis world, and is the thing that's got some data to suggest it may work, is parathyroid hormone, which is given as a daily subcutaneous injection. Again, for those of you from medical school and things like that, you may have memories of hyperparathyroidism causing osteoporosis, and that's true. But when you give this medicine as a daily injection, you get a stimulus of the osteoblast, and this basically causes sort of obviously increased bone formation. And what you can see is there have been clinical trials, and this is the one main clinical trial with Colles fracture, showing that there was a reduction of about a week in fracture healing time assessed with radiographs and function. Now, for a lot of people, that's maybe not a big issue, for the average person that breaks their arm. But obviously, if you're an elite athlete and you've got sort of competitions, or you've got sort of a sort of an event you need to be ready for, this might make a very, very big difference. And again, there have been small case studies and series of pelvic fractures, metatarsal fractures, where again you seem to see the same sorts of improvement. And when you look at the biochemical response, and I've just basically sort of summarized these here, the way this drug works is it stimulates bone formation quite a lot, you can see in the dark line, and then it also does stimulate bone resorption. But basically the difference between the dotted and the solid line is essentially the new bone that you're able to build. So I think, again, what we're learning with these markers is it's the sort of the relationship between the osteoclast function, so the CTX level, and the P1NP level, that actually then will help you understand what is happening at the sort of cellular level with regards to both how the healing process is going, and then whether the treatments you're going to give are actually going to make any major difference. So in summary, I think although obviously a lot of these fractures are all going to be looked after by the surgeons, the radiologists are going to be involved, I think it's worthwhile remembering that if you've got a bone physician in your clinic, to sort of tap into them. One, because obviously it's important to look for secondary causes, and Cathy highlighted the things that could be important. Obviously, again, there's a lot of interest in bone health with regards to calcium and vitamin D. I think, again, looking at their response to healing, and again, if patients are not responding as anticipated, either maybe that they would be suitable for medical therapy, it might reduce the healing time, it might again stop non-unions, or again even implant integration once the surgery's been done, a sort of a belts and braces approach. So with that, thank you very much indeed.
How do we manage bone stress injuries of the foot and ankle? Well, we do the simple things well most of the time, and it often goes very well. Make an accurate diagnosis, not only in terms of the injury that we see, but any other distracting injuries that might be present. Very importantly, recognize the high-risk injuries. There are more to add to this list, I'm sure, but certainly foot and ankle. Medial malleolus, navicular, proximal fifth metatarsal, sesamoids. And beware the patient who's got diffuse bone marrow edema. As Monica said, when we see that, you have to start to ask greater questions, particularly about the physiology of the bone of the patient that we're looking at. And often these patients will be truly the people who do have significant bone health issues. So we have to recognize the high-risk injuries that are either under tensile stress or prone to a lack of vascular supply, but we also have to identify the high-risk patient. And the high-risk patient I would define as somebody who clearly has a predisposition to bone stress injuries, whether that's through impaired so-called bone health or not, whether it's due to behavioral or adherence issues to rehabilitation and treatment programs they're given, patients who are under a lot of environmental or coaching stress to get back into training quickly, that's a high-risk patient. And then obviously the broader topic of the athlete triad, which we don't really have any time for to cover today, but they are a distinct group of individuals who need identifying because they will need much more intensive, holistic management of their health. Individuals with eating disorders, energy imbalance, low body mass, hypogonadism, bone health issues, need multidisciplinary team management. They need to be taken out of the training environment if necessary. They need to be put into a safe environment to recover. And recovery means recovering a positive energy balance and normal hormonal function. But in general, we start with making an accurate diagnosis. We recognize the sinister injuries and the high-risk patients. And we have to identify the causes, as I've already discussed and the others have discussed, really thorough assessment of any individual presenting with a bone stress injury. Have you addressed the whole bigger picture of the athlete's bone resilience? And assess objective measures of bone health, as Monica and Richard have already commented on. Phase 1 of management of the injury itself: offload the injury, relative rest, which means offloading it to below pain threshold. Jayne is going to talk about a lot of the loading strategies that are used, so thankfully I don't have to cover them, but essentially you're trying to immobilize the injury to below pain threshold, and with the higher risk injuries, you may want to be quite aggressive about offloading that patient. Continue other training as you can in order to maintain cardiovascular and health and muscular strength. Nutrition, balanced diet, which means adequate calories, adequate protein, adequate calcium intake. Much is made about the vitamin D story. You know, everybody screens their patients for low vitamin D levels in relation to bone health, but correcting vitamin D is rarely the only thing that is going to achieve a good bone health in most of these patients. The serum target for ideal bone health is here, and that's higher than often you will see on normal reference ranges on a normal GP result printout. And then there is the arguments about how important is vitamin K, and certainly what is important is making sure the patient's got adequate protein intake to promote recovery. What about the use of analgesics? Well, typically as little as possible to avoid masking of the injury. Sometimes people with severe bone stress injuries do get pain at night, and we will try to restrict analgesics to paracetamol, a bit of codeine if really necessary, avoiding non-steroidal agents because they are not good for bone repair. And don't forget, you know, often when things don't go well with the repair of a stress fracture, it's because of the behavior of the athlete and the people around them. So make sure that the athlete and the support team understand the injury, they understand how to take care of their bones and what the treatment program is so that they can completely embrace it, because typically they are the ones who will determine their own destiny. So making sure that they're really clear on what the management plan is. And, you know, we can talk about modalities, but as with so many of these things, the evidence base for using modalities to try to promote bone healing, so low intensity pulsed ultrasound, exogen units, or suitably adapted ultrasound units in physiotherapy clinics. There is case control level evidence of increased rapidity of recovery from bone stress injuries in the foot and ankle, but as I say, the evidence base is limited. And you know, I will use these in athletes, but what I worry about with them is that we feel that it circumvents the need to do the other things well, and that's where the danger are. Reflect on the causes of injuries. We've covered this pretty well, but make sure that you take the time out during that phase 1 with the patient to make sure you are covering all the bases so that you are not seeing them again with a recurrent bone injury. So review their mechanical loading programs, review their recovery strategies, and reflect on whether the bone properties are healthy or not. Phase 2 is really when they move into a pain-free stage, typically after 10 to 14 days, no focal tenderness of the bone, and they're psychologically ready to return to some training, and they should then progress their loading through a supervised program with their physiotherapist monitoring the response. And the criteria for progression is not based on time, it is based on symptoms, readiness, and achievement of performance targets during that rehabilitation program. What about further interventions? Well, if the individual has got any underlying medical reason why their bone remodeling is not correct, then that should be addressed, and that perhaps is stating the obvious, but it's probably the first thought in terms of intervention that should be had. When do we need to consider other interventions? Well, most stress fractures will heal with that response, with that approach. Consider other interventions if we perceive there is delayed healing, and that's an individual decision between the athlete, their doctors, and it's based on the individual, their sport, their competitive schedule and requirements, the site of the fracture, and the grade of the injury. And I suppose the question that every athlete will ask you is, how long will it take me for this bone injury to heal? And the answer is, there's a lot of difference between individuals on this. This is a study from the military that looked at timing of single metatarsals versus multiple metatarsal stress injuries, tibia and fibula, across different grades. But you can see here, this is number of weeks, that the range was 8 to 50 weeks in single metatarsals, 12 to 18 weeks in multiple metatarsals. I don't quite understand why it's shorter. Tibia and fibula, similar concepts. So basically, actually, usually the answer is a lot longer than you think it will take. And certainly, I think this range would surprise a lot of us. This has also been looked at in other studies. I'm sorry I haven't put the reference range in here, but this is a study that looked at average time to return to sport after stress fractures of the foot and ankle. And if you look at low risk, low grade injuries, it's 61 days. High risk, high grade injuries, 131 days. If you look at this one, so the perceived low risk site of injury, but a high grade, that's the longest. And to some extent, we can be a bit complacent about what we see as a low risk injury. We might try to return the athlete to sport too quickly, and perhaps this is why actually the mean time to return can be quite significantly delayed. We should anticipate a slower progression in people who've got high-risk injuries if they're a high-risk patient or their injury is a high grade radiologically. If they have rest pain at diagnosis, if they have a longer duration of symptoms prior to diagnosis, if they've got a lower fitness level, they're older, or there's any underlying impairment of bone health. Richard has already mentioned the fact that if we really do have to intervene, if we perceive delayed healing, then from a medical perspective, teriparatide has case report level evidence of benefit with treatment over the course of 4 weeks. It is considered to be quite a low risk approach, but reserved for those people who really do have delayed healing. I will mention bisphosphonates, and I will only mention bisphosphonates because everybody else mentions bisphosphonates in sports medicine, and they probably shouldn't. There are case-controlled studies of the use of bisphosphonates in trying to promote healing of stress fractures, but I think that many of us would agree with this comment. You should not use them, essentially, in athletes who have bone stress fractures. The thought process, the rationale doesn't make an awful lot of sense. And if we really do need to intervene with agents, there is teriparatide that's there for that purpose. So in summary, start with making an accurate diagnosis. Have you identified all the injuries? Have you identified the high-risk injuries in the high-risk patient? Identify the cause, educate the athlete and the support team, and be aware that most injuries will actually respond to sensible, kind of, quite frankly, non-medical approaches. But we have to recognize that there is the need to intervene in higher grade, higher risk injuries in some individuals. Thank you.
I suppose the answer is, as we've found throughout this meeting, it's a multidisciplinary approach, and hopefully the surgeon will be involved at an early stage, if only to say everything's fine, just wait. Just got one disclosure to make. Well, let's start with the more straightforward one, the common one that has already been alluded to. I actually took a slide out, which I'm sure James is familiar with. A few years ago, somebody, I don't know who it was, you can find it online, they went ahead with, looked at football managers' predictions of return to sport and people's actual return to sport with metatarsal fractures. It's in the days of Beckham and the Nevilles. And as you can imagine, 6 weeks, that's what the manager says. And then they put, when they actually did go back, which as we've seen from Cathy, can be months and months and months. So don't listen to football managers. Hopefully, our lesser metatarsal stress fractures 2, 3 and 4 are going to heal quickly. What am I concerned about? Well, I'm concerned about those who are delayed and non-unions, and obviously we'll take into account all of the factors we've already been told about. They're not benign injuries. Sometimes you can get malunions, we'll see. And just a word about basal fractures. Many of our professional sports people do often get a prodromal feeling of pain, and they will often have an MRI scan which may show some focal stress edema. Just be careful with those, because those will on occasions go on to a full fracture. So basically, as I'm glad I've heard already, it's basically for me it's usually CT scans and screws. That's the message. Those that are not healing, over 6 weeks, I usually want to see a CT scan. They're often basal injuries which are slow, and if they don't heal, then we're going to usually think about plating. As you can see, sometimes we've actually got very little bone to work with proximally, and there may be occasions when we've actually got to bridge. In this one, with a kind of a T-plate, I was able to get enough fixation proximally. We tend to tell our lesser metatarsal fractures they'll just walk on it when you're ready, but if their bone physiology is not right, then they may bend, and as you can see, we've got a bend on this one. This will lead to transfer metatarsalgia, and you may see also that they're beginning to get a little bit of degenerative change in the metatarsal head. So just be a bit careful, and there will be rare occasions when you may want to go in and re-osteotomize these. Just a word about stress fractures of the base of the fourth metatarsal. I'm going to talk about fifth metatarsals in a minute, but we are aware that the base of the fourth metatarsal can behave a little bit like base of the fifth metatarsals. We tend to think, as we've heard, that most of our second, third and fourth diaphyseal fractures will heal in 6 to 8 weeks, but Saxena demonstrated that a proximal fourth may take double that time. So A, shut them down, rest them as much as you can, but be prepared they may take longer. Right, fifth metatarsal stress fractures. Well, what we've got to do initially is to be sure what we're talking about. So we've got tuberosity fractures, we've got the classical Jones fracture where the line actually runs into the articulation between the fourth and the fifth, and then we've got the stress fracture. And essentially, the personality of the fracture gets worse because of biomechanical and vascular issues as you go distally. Well, Gino Kirchhoff and Nick Van Dyke in this paper said, who should we be operating on? Well, I think James would confirm with me that we've got more aggressive with our athletes and people who are generally active. Clearly, if they fail conservative treatment or when if they present late, they've already got a non-union. This paper gave some very promising results. 32 stress fractures in elite athletes healed and returned to sport in average of 10 weeks. Well, Kirchhoff went on and they looked at 21 papers from the literature of proximal fifth metatarsal fractures. I'm sorry, these have slipped a little bit. So avulsion, Jones, stress, fracture union, get back to work, get back to sport. If we treat them conservatively, the Jones fracture has averaged 17 stress fractures, 19 for healing. If we treat them non-operatively. If we operate on them, you can see that they apparently heal certainly a little bit, well, the fracture union is about the same. They're going to be longer getting back to work because we've operated on them. But in terms of return to sport, you can see that actually they will be going back early, particularly in the stress group. What about those that don't heal? Well, I think if you treat your Jones fractures in the sporting population, if you've got a Jones fracture, about 1 in 4 will be delayed healing. And if you've got a stress fracture, it'll be about 1 in 3. If you operate on them, then you can see your percentages drop enormously. So this is a fairly positive thing for saying we should be operating on them. However, and once again, this is Nick Van Dyke, he looked at 246 cases. He was very critical of our research, as often the case, unfortunately, with orthopedics, many methodological problems. And in this paper, he said that there was a trend for surgical treatment to result in an early return to sport, but it was not statistically significant. So we just have to be a little bit careful. We've got many different ways of fixing fifth metatarsal fractures, but essentially intramedullary screw fixation is really the way forward. I think we've all tried plates and other things in our youth, and they really don't seem to give the same results. It is now the treatment of choice. We can do them through very small incisions. We're trying to use a solid screw, which is stronger. We're all told to go high and inside. This is the baseball pitcher's particular ball to try and get our position. And you just try and get the largest screw you can up it. And sometimes we may want to put some bone marrow aspirate in. And also just leave them in. Don't take them out until at least the athlete has decided to retire. 2 years ago, James asked me to talk about sesamoid fractures. I realised there was very little actually out there. So as a result of that, Beat Hinterman and myself just put a review article out last year about it. What do we know about stress fracture of the sesamoid? We don't know anything about its natural history. It's not out there. What do we know about the outcomes of conservative treatment? We have no idea. What do we know about surgical stabilisation? Well, we've got small case series only, and they mix up acute, stress, chronic. We really don't know where we are. What we do know is that people like Sachin Tendulkar had a stress fracture of his sesamoid at the age of 21 and played his entire cricket career very successfully with it. So the level of scientific evidence is dreadful. How can we treat them if we're going to operate on them? Well, screw fixation, either open or percutaneous, and you may decide to graft. More commonly, you may decide you're going to do some form of sesamoidectomy. Here's a lateral sesamoidectomy, partial or complete, plus or minus reconstructing the soft tissues. And finally, many of these patients have got other pathology. They've got bunions, they've got abnormal angulation of their metatarsals, gastroc tightness. They may need other things dealing with. This is what some of the x-rays look like. So we've got a percutaneous screw fixation here. This is one of Beat Hinterman's cases, an open reduction of a sesamoid fracture here, and he's also corrected the bunion at the same time. So who should have surgery on their sesamoids? As I say, we don't really know. Failure conservative treatment, and if it's painful, and it said symptoms for 3 to 6 months. But if you've got a painful sesamoid non-union in an athlete, I suggest you'll go earlier. If you're feeling brave and it's minimally displaced, no avascular necrosis, then you may go for a percutaneous screw, otherwise open. If the displacement between the bone ends is greater than 3 millimeters, then it's going to be more difficult with a screw, and you may well decide to go for some form of sesamoidectomy. If you've got avascular necrosis, and this is where we rely on our radiologists, then you're really looking at a sesamoidectomy. If you've got an eccentric fracture, this means it's not a waist fracture, but it's often more to the distal end. I had one of these 2 weeks ago. Then you may just do a partial sesamoidectomy, otherwise a total sesamoidectomy. There's been a lot of fear about sesamoidectomies. Don't forget your predisposing pathology. But when we reviewed all of the papers and published this, your likely return to sport is about 88% from what we could make out, and there's a 9% risk of developing a post-surgical bunion in years to come. So those are the figures you need to give your patients. Navicular stress fractures, we've seen an awful lot of these. There's a fantastic review article by Jim Nunley, which I would, anybody interested in this, have a look at. Basically, it's CT as far as I'm concerned. The first thing you need to do is to grade it. Is it a grade 1, just involving the dorsal cortex? Is it a grade 2, or is it a grade 3 going all the way through? This will determine your treatment options. Who should we operate on? If it's displaced, if it's going all the way through, if it's looking sclerotic, or if it's comminuted. Obviously, if conservative treatment has failed, and arguable type 2 partials, bilateral, and elite athletes. So, what are our options? If you've got an acute fracture, then I think you're probably going to fix it percutaneously. If you've tried conservative treatment and it's failed, if it's just a type 1, then I think probably percutaneous. You may think about open. Type 2, similarly. When you get down to the type 3s, when they've gone all the way through, then I don't think percutaneous is reasonable. I think you've got to open it and properly graft it. And if it's sclerotic, fragmented or displaced, then you're opening, drilling and probably grafting. You're going to use 2 screws usually for stability, as we've seen from previous x-rays. We usually go from lateral to medial, and once again, screw size 3.5 to 4, and then you have a decision whether you go for the stronger solid or a cannulated. So here we have an international athlete at the age of 22, type 2 stress fractures, 4 months apart. We elected well, we did the first one and then we had to do the second one. They take time to get over, but he's recovered, and this year he was the European indoor champion. Then we've got the kind of patient that may come to see Cathy. It's a 20-year-old female, 12% body fat, mildly osteopenic, second in the Junior World Champion Triathlon Championships. She developed 6 weeks of pain, and then this was her CT scan. Now, I think it's graded as a 2. I think this is probably a vascular marking here, but it was looking a bit sclerotic. So I really felt we've got no choice but to do something with this. So once again, 2-screw fixation, but this time I opted to open it and to put some bone graft in. And she's come back, and she's once again in the seniors now and doing extremely well. So, conclusions. Treatment remains controversial for navicular stress fractures. There's no clear standard of care. As we've already heard, CT scan. There are indications that if you strictly non-weight bear them for 6 weeks, particularly in the type 1s, those small dorsal ones, then the results are as good as surgery. But are our athletes going to be compliant? And if the diagnosis is delayed, does that affect the response to non-weight bearing? There's clear indications for surgical intervention, displacement, comminution, sclerosis, however it's not clear for others. And finally, medial malleolar stress fractures. Once again, we've heard about this. I just want you to note this little bump of bone here. I know James always remarks about this. This is actually kind of going into the ankle, and you sometimes see it with these. If you have a patient, you have an athlete who's got medial malleolar pain, don't be surprised if their first x-rays are normal. This paper said only up to 30% show it on the first x-ray. There is a lack of good evidence to support conservative or surgical treatment. However, if it's displaced, if it's showing evidence of cysts, if it's obviously osteoporotic and failing to progress, we've got to think about surgery. And then the relative indications are the level of intensity of the sport, and also, is it towards the end of the season? Have they got time to heal, or have we really got to get them back quickly? So, surgical strategy. Zakaria Rava, David Beckham's surgeon, he went 20 years ago, said just drill them and try and stimulate healing. I'm not sure, James, whether we'd get away with that now. I think most people feel we need to fix them, compression screws. Some people will use a plate. I would always do an ankle arthroscopy because they've often got that little bump of bone in the front just causing a bit of pain that needs shaving. And some people have said if they really do have significant biomechanical abnormalities, then correct that, but I think you'd be brave to do that on a first-off treatment. There's only small series and case reports, and return to sport is variable from 5 weeks to 7 months. Final case, this is a 31-year-old professional footballer who came to see me last summer. This was his stress fracture here, going through here, and this was him 6 weeks post-surgery. And he was delayed getting back into pre-season training, but he got back, 18 appearances and 5 goals in Division 1, so a reasonable outcome. So, thank you very much indeed.
You lot have done the easy bit now, so you've done your scans, you've done all the quick stuff, and you pass it over to the physio. How many physiotherapists have we in the room? A few, quite a few. Okay, so we're left with the months and the weeks of cajoling the patient and getting them to do what we want and getting them to understand why they have to do what we would like them to do. So what I'm going to do today is talk a little bit about the necessity, first of all, to understand foot mechanics exceptionally well if you're going to rehab people who have this type of injuries. Who here has a qualification in physics? Do your patients have a qualification in physics? Very unlikely. So when you, as surgeons or sports doctors, say to them to load to a certain level, they just simply don't understand you. So the physiotherapists that are here, I want you to be very, very clear to your patients about the level of loading. I spend about a third of my life explaining physics to patients about what is load and getting them to buy in. I draw these lines at the bottom here regularly to explain to patients how long it's going to take. And it was very interesting what Cathy said about it taking up to 50 weeks. Because I think they see the patients who return to sport in 6, and it's very unrealistic for certainly most of my patients who've got multiple pathologies who go on to just to get stress fractures to think that they will recover in the same way. Active rest. So whenever they leave and the consultants say active rest, the patients don't understand this concept either. So I think setting a very, very clear plan right from the start. Don't let them plan their own CV, because they don't understand that cycling is not necessarily non-weight bearing, especially if they go to a spin class and decide to stand up in the middle of spin class and spin. That's not non-weight bearing, but they don't understand this concept. So and the same thing goes with weights. Patients do quite heavy weights standing up whilst in their boot and think that they're doing non-weight bearing. So I spend a lot of time explaining how they're going to do their weights and that they can do them, that's the other thing. Some patients go completely the other way and do absolutely nothing, which is devastating. And if they have half an hour with you where you enable them to do all their core and their hip control right from the start. Now, I'm a massive believer in trying to find out why the patient has a particular stress fracture in a particular joint. So the imaging is fascinating. What is more fascinating for me is to find out why they have a 5th metatarsal fracture and not a 4th, or why it's not on their 1st. And all those mechanical loading aspects that we talked about, you can actually, in some athletes, get video of them from before they were injured. I have a series of triathletes who've got quite detailed images of them running in their gait, and you can actually look at those from the beginning and convince them that they are going to need to change the pattern of the way they move during their rehab. Imagery, I don't know whether anyone uses imagery. I use imagery to encourage the patient to imagine that they are still walking and running so that they still maintain the motor aspects of what they're trying to achieve once they come out of their boot. For anyone who puts a patient in a boot, can you please remember that when you put them in the boot, you're creating a leg length discrepancy. So you need to get them into a thing called an even up. You can buy them on Amazon. It slips on the outside of your shoe and it makes your legs the same length. Very useful bit of kit. So the first thing I tell them is that they are their own physics project, and spends a bit of time teaching them about levers, getting them to understand when they should do certain things, and drawing a very clear line of progression about when they're going to do certain activities. First thing I do is say to them all of these questions to make them understand and think about the load capacity that they're putting through their foot or their ankle, to make them understand that they can't just carry their children upstairs if they've been made non-weight bearing, just because they're in the boot. Teaching basic physics and body weight control to patients is vital, and I think that it would be very useful if it started right at the very beginning, where you say to your patients that walking does not equal running. I think that once they come out of their boot, a lot of them think that that's the end. In fact, that's only just the beginning. And I tell them this probably from the first week, to make sure that they understand the control and the resilience and the endurance that they're going to need throughout their return to play. It was interesting what Cathy was saying about resilience in bone. For the patients, after they've got their bone structure sorted, the resilience and endurance within the muscle groups that support those structures is absolutely vital. So these are some of the little gadgets I use. Patients love gadgets, physios love gadgets. I use informatics. This is on the left, an informatic about running injuries by a group out in Australia called Clinical Edge. Apple apps are fantastic. This is actually a decibel reader. It's a free app that you can download onto your phone. It's worth looking at. It'll become apparent in a minute why it's useful. For anyone who was at the lectures yesterday, Sean's here. So we talked about this yesterday. This is a piece of work done by Irene Davis and her team about control and core control of the foot. And this is one of my passions, and you'll see why in a minute. Once you have sorted out the structure of your foot, it is very important that that structure then is supported. Now, it's no coincidence that last night that we were in the Civil Institute of Engineering next door, and there was loads of domes and beautiful structures that were held up beautifully. My husband's an engineer, so he's interested in engineering, and your foot is probably one of the best engineering projects that you could ever imagine. But if you don't have the structure, the soft structures to stabilize it, then you will re-injure. And I spend a lot of time talking to the patients about not having a reoccurrence of this. This is a little exercise that I teach the patients, and it's about trying to shorten from your first metatarsal to your heel to recorrect your foot position. The next slide I'm going to show you is actually of myself doing this exercise, but also gaining a foot neutral position. Foot posture within patients is actually very, very poor. So I spend quite a lot of time trying to get them to control into subtalar neutral and also maintain their arch. It's very important to teach the patients how to control the abductors of the great toe so that their great toe stays in a linear plane. Also to increase the control within their flexor hallucis longus and the peroneus longus, so that when they go to plant their foot on the ground, their foot doesn't end up with the fifth metatarsal being the first point of contact. These are a few little progressive exercises. The foot strengthening one on the far side, you'll see that you need to be able to keep your great toe off the ground and be able to shorten. This is a stability exercise. You'll see that I'm able to sway and keep my arches and my foot in neutral while I'm doing it. Heel raises, I expect the patients to do 25 of these again and again, again, both of gastroc and soleus before I'll let them to return to any level of exercise. And also, just because you can hold your foot in neutral and your arch in neutral doesn't mean that you can do it while doing activity like bending your knee. The same thing going to hop. There's no point in giving a plyometrics program to someone who actually can't control their foot structure when they're doing a simple hop. These are some little ballet exercises that I teach the patients to do for their flexor hallucis longus. Progressive exercise through different positions is vital. You can teach all these exercises that I just had up there in sitting. You can actually teach them in non-weight bearing to start with, so that they understand the structure and the function of their foot before they even start the weight bearing phase. This is probably the most important part. Teaching gait so that they progress through their great toe. The mechanism on your foot will only, the windlass mechanism on your foot will only load correctly if you high gear off your great toe. It won't work correctly if you low gear off your fifth. So going through these level exercises, I saw there was some slides earlier about aqua jogging and underwater treadmills. Just a little bit of word of warning, your biomechanics are very specific to what you're doing in which substance. Aqua jogging does not equal jogging. There's no ground reaction force for a start. The ground reaction force also changes in underwater treadmills, and it changes your biomechanics once it passes your ankles. So your normal biomechanics and the muscles that you recruit in an underwater treadmill is nowhere near the same as what it would be if you were on dry land. Landing. I don't think that landing is taught particularly well, and as physiotherapists, we need to spend quite a lot of time teaching light landing, correct foot pattern landing, especially in running. I spend a lot of time looking at people's running mechanics and correcting them, and correcting their loading patterns and where they strike the ground, whether they're overstriding, whether they're striking on the lateral border of their foot, and correcting a lot of dancers into the position that they're actually hitting the ground and how they absorb the shock correctly. So I teach them to be a little bit more ninja and a little less thunder or a little less elephant, and that's where the decibel reader comes in. I use all sorts of little gadgets and tricks to get them to land more lightly. So these are my rules. It's actually quite hard to find anything in the literature that backs these up, but they're good common sense rules. If you don't understand physics, then your patients won't. So get your old physics texts out and get yourself educated in your patients. If you can't stand properly on a single leg and maintain the arch of your foot and your subtalar neutral position and the whole of your kinetic chain, you're not going to be able to do it whenever you hop or land or walk. If you can't hop 40 times in succession and not get any pain and land correctly and lightly, then you shouldn't progress to running. If you can't walk 5Ks, I don't let my patients then go onto a run-walk program. And you can't start running unless you've had a detailed running assessment to figure out why you got the issue in the first place. If you can't run 5Ks, you can't increase your speed.
Question for I'm James Brown from British Athletics. Question for Richard and Bill. We've got an elite athlete sprinter with a grade 1 navicular. Do we start them straight away on teriparatide and non-weight bear them in a boot, or do we operate on them?
I'm interested to hear what people think about teriparatide. When I was at the American sports meeting 3 years ago, it seemed, particularly with the baseball group, that everybody, all the baseball guys were getting teriparatide, particularly for their metacarpal fractures. I've only got the experience of one patient, which is one of our Olympic medalists in gymnastics, who had a stress fracture of his oscalcis, and he was put on teriparatide straight away. I have to say his recovery was astonishing in terms of getting back, but that is all that's my only experience of teriparatide. And I saw that people said, well, you should only use it later in the, if they're not recovering, whereas the Americans are going for it straight away. So I'm very interested to see what the American experience is going to be. It does seem to be, and what we hear was not particularly a risk drug, although I have to wait and see. But in terms of a grade 1 navicular, if it's picked up early, I personally would still go for conservative treatment, because they've got to be non-weight bearing and they've got to rest it. But I think the evidence is fairly good for that group. Whether you add teriparatide, I suspect in the next few years we may well be talking more and more about it.
Yeah, I mean, I agree. I mean, I think we are changing slightly, and I'm sure that following the Americans, and the fact that if you've got a patient who isn't going to need surgery and it should heal, then I think as long as there aren't any contraindications, and again, I think the most important one is if it's an adolescent who's not yet fully skeletally mature, then obviously that would not be an ideal group. But the risk in using 4 weeks, 6 weeks of teriparatide is pretty small. And again, what we don't know, of course, is does it delay them, or does it stop them going on to then need surgery in the longer run, possibly, because that's the thing we don't know. But I think if they've got an elite performer, if you can reduce the chance of them needing surgery, then I would think, yeah, no, not a risk.
James, have you got?
Can we have the microphone down here? Yeah, and I think I think it's a low risk thing. I'm not a physician, so I don't know. But one thing coming back with Richard, that study that suggests there was no difference using paratide in PTH. There we go. It's easier. In collies, I mean that's a different group.
There was a difference. It was about a week to 2 weeks sort of improvement in time to healing.
But that's a different group of patients,
group.
isn't it?
Yeah.
It's not the sort of the elite athletes, and so I don't quite know how transferable that is across.
I think the problem is I mean, doing a randomised controlled trial in fracture healing. I mean, even that one was really difficult. Doing a randomised controlled trial in elite athletes, I think. But then we run into what would be your outcome measure? Is it radiological healing? Is it just reduction in pain doing activities?
Yeah.
Again, I think there's lots of case series growing in numbers with regards to, as I say, just returning quicker than you might have expected.
Yeah. I think when we say PTH, because teriparatide is not pure PTH, it's the shortened version, so it doesn't act exactly like the normal natural
hormone. It's PTH 134.
Yeah.
So it's not.
I think in a high-risk injury, it's a much easier decision to use teriparatide. It's more the low-risk injuries that you think, is this really overkill?
Mainly aimed towards Cathy, but I suppose the whole panel could chip in. Cathy, you mentioned about for bone healing, there's a kind of a 12-hour period. And the big dilemma for physiotherapists is, I mean, after you come out of the boot, you then have to reload the bone. It's not just the muscle. You have to obviously reload the whole muscular system, but you got to reload the bone again. Mm-hmm. The bone has to get used to tolerating high loads, especially in sport. So, I mean, there's always a dilemma. When I worked in football, it's about when to load and when to offload and when to reload again, and you base that on your symptoms the next day. But from a medical point of view, I mean, we're always looking for help, and from a turnover point of view, from a blast in a class, do you have any recommendations for, I suppose, physios in terms of, can you load twice a day? If you're saying a 12-hour turnover, could you realistically load in the morning in a sensible way and then reload them again in the evening?
Yeah, I mean, I think the point is that what you've got to look at is what load you want to impose over a 24-hour cycle, and then be clever about it and split it into certainly 2 bouts of loading.
Gotcha.
So if you can separate it out by morning and evening or morning, late afternoon, then you're much more likely to get a positive osteogenic stimulus that way than you are in trying to do 1 loading bout a day.
Gotcha.
And you can still then look at them the next day and see how they've responded and decide what the timing of the loading is then.
Gotcha. A bit like your OA example where you got your old lady who's walking to the shops and you ask her to break up her walk rather than doing it all at once.
Yeah, but certainly, but this is very much about maxing out on the positive effects of that loading stimulus, rather than thinking that by doing it in 1 session you've got longer to recover. What you want to do is to try to get the maximum positive out rather than overload them in 1 session.
Gotcha. Very good, thanks.
Can I ask Cathy, because in the tendinopathy session yesterday, it was discussed that your maximum response from your tenocytes from loading is about 3 days. If you've got a patient who's coming back from a bad injury and they're just coming back slowly, you said very clearly that for maximising bone health, then you can load them quicker. But if you've already got your tendons already coming back, is there a risk of getting optimal bone health, but then
practically speaking, probably not, because you're bringing them back at a slow progressive load. So you would expect, as long as the immobilization hasn't been excessive, that the tendon could still cope with that. So I think you would need to regard that the bone would be the most vulnerable point, and actually load them according to the bone as opposed to the tendons. I mean, you would not want to be doing, for bone recovery, you wouldn't want to be doing a once every 3 days cycle, would you? No.
Thanks very much for an interesting session. John Grice, Swindon. Question for Bill. You mentioned in a grade 3 navicular stress fracture you feel that open reduction and bone grafting is the way forward. If you had an undisplaced, fairly acute grade 3, would you always then open and disrupt the biology, or would you consider stabilising it if it's on CT, you don't have any reduction to perform?
I have to say the grade 3s, I just seem to find that if they're going through, even though they're acute, they often may have had something going on before. Often it looks a little bit sclerotic anyway. I'm not saying that you should never consider percutaneous fixation if you've decided to, to operate very early, but I would have a much lower threshold if they're going all the way through and they look a little bit sclerotic to open them, drill them and graft them.
But do you think the sclerotic ones are the slightly undermanaged grade 1, grade 2
I think
ones that we've not quite...
I think the grade 1s are difficult. And it was interesting seeing the imaging of the one that broke down, because I don't know what you've seen, but often you get that last dorsal bit which never heals, and we've seen some of the international athletes who had them as 19, 20-year-olds, and you see them at 32, and they're rescanned, and they've still got a bit which is never healed at the top. So I think they are difficult, that group, and I would also say I think with those grade 1s, from a technical aspect, because as you know, they don't go down very far, and then when you put your screws in, you actually because the screws are probably going underneath it, and they're just stabilising it. So there is that question.
Preventing a propagation.
Yeah, I think that's right. You know, having worked with me, I think what we do is you get the house with the walls that are falling apart, and all we're doing is we're putting a screw across it to stop the walls falling apart. We're not trying to push the walls together. But I think, Bill, I think it's more of a vascular problem.
Yeah.
And I think it's the problem we've got with when we do the open reduction is we then devascularize it even more. That dorsal cortical fragment that sometimes becomes loose is a vascular problem. And when it goes to a complete fracture, I've now taken a slightly more aggressive approach. And we've only got a few, but I followed Jim Nunley's approach, which he wrote about years ago, and we ignored because it looks very, very difficult. And I do a vascularized pedicle graft, because it doesn't heal. It really doesn't heal.
Yeah.
Possibly slightly off-piece question, but whilst we've got Richard Key on stage, I've got a number of patients over the years who've had this sort of migratory bone marrow edema, transient migratory osteoporosis thing. Have you got any tips for how to speed up the healing or the resolution of this? Because these can be really difficult patients to cajole on.
Is this in athletes or just
general? Not so much. I don't think you see it in athletes so much.
I mean, again, Cathy, this would be the one group of patients sometimes bisphosphonates do seem to work in. There's some data with ibandronate, and probably that given that that's got a shorter half-life than some of them, I think that seems to work quite well. There's some quite good studies out there showing that 1 or 2 treatments seem to reduce the bone edema within, say, 6 weeks and basically get rid of the pain pretty quickly. So that I've got quite a low threshold for a number of patients who've got that sort of bone edema, transient osteoporosis, whatever you call it. Bisphosphonates seem to work well.
So, Bill, just on Billy Jack from Portsmouth, on the topic of navicular stress fractures, do you use CT scan before you allow your patients to return to sport?
I have to say, traditionally, I haven't. I tend to go on X-rays and clinical progress, but I know that if you read Nunley's paper, he's adamant that you really should be re-CTing them and taking them through until you're happy it's united. So I think my practice ought to change, and I ought to do it.
And then how much does it have to be united for you to be satisfied?
Well, I'm slightly worried because having seen that X-ray, having seen that case, I've tended not to be too worried if that dorsal bit is still a bit slow, as long as the patient's comfortable and everything else seems to be okay. But perhaps I might need to think again. But equally, as we've said, we might be waiting 12, 15 years. As a certain lady from UK Athletics who did amazing things with.
I was going to say probably a moniker involved in that, because my feeling is they don't bloom and heal the top bit. No. Just you see them years later.
Well, yeah, I wonder whether that patient was just painful, so clinically required a repeat CT. I mean, there was a big interval, 3 months in a way. That's quite a significant interval, and whether they were having continued pain and therefore went on to have a CT at that time. Yeah. But you do see that quite often.
Yeah. No further questions. I'd like to thank the panel very much indeed. Very clear advice. Thank you very much.